So good morning, everybody, and welcome to Understanding the Connection Between ACEs and Substance Use. Ruby Parker is here with us today, and she's the Engagement and Education Director at the Maine Resilience Building Network. She's going to tell us a little bit more about that subject. First, I'm going to do a little bit of housekeeping. If you can, mute yourself. Your camera is optional unless Ruby asks you to turn it on for an activity later in the session. And then if you could work with your supervisor for your attendance and your CEUs, we'd appreciate that. And lastly, the June Lunch and Learns have been changed to July 21st and July 26th. So please check your calendar. If you don't have those appointments, reach out to Sam or I and we'll forward them to you. But without further ado, I'd like to introduce Ruby. So Ruby, take it away. Thanks for joining us today.
Thanks, Ginger. Thanks for the invite. I'm going to go ahead and get my screen sharing situation up here for you all. Okay, are you guys seeing my screen? I hope that's a yes. I can't see anyone's faces. Teams is a little bit different for us. Thanks, Sam. I always just worry. Teams is a little bit different than what I'm used to presenting on, and I always have to refresh myself when I get started. So thank you guys all so much for joining. My name is Ruby, as Ginger said, and I work with the Maine Resilience Building Network. Some of you guys may have already seen me present. And if you, I want to see, before we get started here, let me figure out where I was gonna have you guys use the chat, but I'm not sure if I'll be able to see it while we're going. And I apologize.
If you want me to monitor the chat, I'm more than happy to do that.
You know what, that's okay, actually. I think I'm just going to jump into it. I just wanted to let you guys know. So today what I'm going to be talking about, as Ginger said, is recognizing the connection between childhood trauma, adversity, ACEs, and substance use disorders, which means that I am going to give you guys some overview of ACEs. So the only reason I'm hesitating with all of this in my introduction is that sometimes people have had a lot of training and education around ACEs and you go, I know this. So bear with me if you know some of this information. Hopefully some of it's just a refresher, a reminder for us, and that many of you guys have had some introductions. There are probably some people on this call who've not really had a lot of opportunities to learn that. So hopefully in that way, it's a great learning opportunity for you all. And I would say that if there are things that come up and there are questions, because Teams for me is a little bit challenging as a presenter to see the chat, Sam or others, please interrupt me, unmute yourself if there's a question. Just go ahead and blurt that out for me. And I will definitely try to wrap up with a few minutes to spare to address any questions as well. So you guys are pretty familiar with the Maine Resilience Building Network. And so I won't get into that there, but I will invite us, because this is oftentimes a lunchtime for some people, or you guys are jumping in from meeting to meeting, I will invite you just to take a moment. We're going to give it 10, 20 seconds to just take a couple of deep breaths and let go of any energy you may be carrying with you from your previous meeting or from your morning, and really settle in before we have this conversation. Great, thank you for doing that. It's an important way for us to be centered in the conversation we're having, especially in the conversations around childhood trauma and adversity. Sometimes we show up in meetings with the professional hat on, or our professional identity of how does this connect with the people we work with? And sometimes it surprises us when what we're talking about actually impacts all of us in our personal lives. So I want to kind of remind you all today that when we talk about our childhoods, as best as we do to try to keep professional hats on, sometimes that feels a little bit personal. It hits us home. And so please take care of yourself. If there's anything that feels uncomfortable, I welcome you to reach out to me separately. I'll provide my email address, or Sam has it. I'm happy to answer any questions or go over information if you had to leave early. And I hope that this is helpful for you all. So before we jump into this, I want us to really have a good understanding of why it is that I'm talking about the connection between substance use disorders. Many of you I know have probably, you encounter work around this, even if that's not your job. You're noticing that either the people who you work with are struggling with maybe identifying substances that they're using, whether they're using it more than they should potentially, or you're seeing it interact with families in different ways. Maybe one of the parents is incarcerated due to substance use. So why is it that we're talking about this? We are still in the mix of what we consider to be an opioid crisis, an overdose crisis. And I wanted to kind of get a sense, a lens of how long has this been going on? What's the kind of, why do we spend a lot of energy talking about this? So this is from the CDC, and it's the kind of what they refer to as the 3 waves of the opioid overdose crisis. And basically what happened was in the 90s, prescriptions around opioids became something that was being used for pain management. And around 1999, what we started to see was kind of the first rise in people overdosing from that prescription medication. And basically for about 10 years, we saw a steady increase in prescription overdoses. What that led to do is that they started to decrease prescription medication availability. So we decreased the amount of prescriptions that were available. However, many people had become dependent on that prescription opioid. And therefore, what we see is around 2010, this second rise, the second wave of overdoses involving heroin. And heroin is a form of an opioid that's available more widely at a street level. And so what we saw is that people, as they were not able to get access to prescription opioids, turned to heroin and were able to find some relief for pain and sometimes their addiction in that space. And that's where we start to see that rise very sharp as you look at that graph there of heroin overdoses. And then very quickly after 2010, we start to see a rise in synthetic opioid overdoses. And this is what we most often know as fentanyl, is a synthetic opioid. And we start to see that those overdoses skyrocketed around 2013. And unfortunately, this graph only takes us to 2019. But what you would see is that those numbers would be even higher today. So we see that drastic overdose. The other reason why this is so important is that it is a massive crisis. What we are seeing in over the last couple of years with the pandemic, we see that those overdoses have gotten even larger. So in 2021, over 100,000 people died from a drug overdose, and 2/3 of those drug overdoses involved a synthetic opioid like fentanyl. In Maine, we've seen our overdose deaths skyrocket as well, and in 2020, we had over 500 people die in the state of Maine from a drug overdose. And that was a huge number for us. And unfortunately, in 2021, that number was over 600 people. So really very much impacting all of our communities across the whole state. So now that we've kind of grounded and understand why we talk about this work, why we talk about overdose deaths, and we want to kind of pull it back to understand, well, why is it that someone maybe uses to begin with? What is kind of the reason for that happening? So when we talk about that, we're going to connect with understanding how our childhood, how our earliest days can lead us to a space where we might start to use substances. And this is where I'm going to spend a little bit of time talking about ACEs, adverse childhood experiences. So again, for those of you who are very well versed in this space, hopefully this is a really nice refresher for you. And for those of you who are new to this information, hopefully this helps ground us in understanding that connection between ACEs and substance use. So when we're first born, there's a lot of conversation about whether our genes set the stage for us, whether it's nurture, meaning the environments we have, or nature versus meaning our genes. And they both work together. Our brains are experience dependent. So that's what I kind of emphasize here is if you kind of think of anything about how our brains are, is that we really thrive on the experiences that we have. They set the stage for us into setting up different periods of learning throughout our childhood. In fact, when we're first born, we don't have to do a lot. In fact, what you can see here is when we're first born, the connections in our brains are very minimal. There is not a lot of connection happening, and that's because we don't expect babies to be doing a whole lot. In fact, I have a 4-month-old baby, and he is just starting to, I'm working on trying to get him to roll over, right? We're not expecting him to be writing papers, feeding himself, doing any of those things. We expect them to have adults to support them along the way and make those connections for them. Now, in the first several years of life, this is why so many kind of initiatives around early childhood are based on birth to 3 or birth to 5, is because in those first 5 years of life, basically every single experience a child has, our brains store that information. And then our brains kind of say, how much of this information is really important for me? And so what we see is that by the time we hit puberty, our brains have gone through a process of pruning, where they actually say what experiences happened most often for me, and therefore I believe that information is going to be important for the rest of my life. So that birth to 5 year is really important because it's kind of all the foundations of brain development are happening in those first 5 years. And it doesn't mean that other things can't happen at a later point, but it does kind of change the trajectory of what that might look like for a child, or how easily it is for them to learn that skill at a later point. So what this means, what this tells us, is that when we see high levels of stress in children, whether that's being visible or not based off of their experiences, we see that their amygdala, which is their stress response, is that little orange part in the center of the brain, is kicking into gear more often than a child who isn't experiencing stress. And when that amygdala senses stress, it acts like an alarm clock for our brain, and it floods our brain with a wave of cortisol, which is our stress hormone. Cortisol makes our heart beat faster so that we can push blood to our extremities so we can run faster. It makes our lungs dilate so that we can breathe quicker if we're running. It helps our eyes see clearer by dilating them so that we can have a clearer sense of what's around us. So it does a lot of things to protect us from danger. However, for children, when they're activating that stress response over and over again, that amygdala becomes what we consider to be a little overactive. It's like a muscle. If you exercise a muscle over and over again, it gets real strong and big. And what means it's very quick to be able to pick things up. And so it's kind of like our amygdala, when it gets activated over and over again, it is ready to kick into gear. And so when you think about those first couple of years, if a child has been activated with stressful experiences on a regular basis, what happens is they are ready to fight that danger very quickly, even if that danger may not be there or it's not as necessary to be there. So what we often see in children who've experienced that is that they have a really difficult time relaxing. They're very much on alert. They're paying attention for danger. They're doing exactly what their brain has designed to do, which is keep them alive through dangerous or chaotic experiences. And it's also really hard for them to pay attention to different things because their brains are not able to absorb new information. When we're in that state of cortisol release, our brains solely are focused on getting away from danger, and they're not able to take in new information. When we pull ourselves out of that danger response, when we're calmed down, we can learn new information. So it's not like our brains shut down forever. It's more that during that time of cortisol release, we aren't picking up new information because we're really focused on survival, which again is exactly what our brains are supposed to do. It's helpful for survival. So stress can look different for different children. Stress is not the same for everybody. So the ACE study, or what we talk about adverse childhood experiences, looked at kind of 10 categories of things that might be stressful or alarming to children. And those include 5 forms of what we call child maltreatment. They're traditional forms of child abuse and neglect. And then also 5 forms of kind of household challenges, things that might be going on inside a home that could be disruptive for a child's learning, for their building blocks inside their brain. So this is where we kind of have this understanding of it's not just physical things that happen to a child or emotional things, but also ways in which the child's upbringing might be a little chaotic, a little unstable. Maybe their parents are separated or divorced and there's a lot of arguing happening inside the home, or there's actual violence happening directly in front of the child or inside their home. Or does a parent have a mental illness that is unmanaged and they might be having suicidal episodes? Or maybe they aren't able to be responsive to a child's needs because of a substance use disorder, and they are, unable to meet the needs of their child because they are actively using substances. Also, parental incarceration, so having an interaction with the criminal justice system, we see there is another thing that might be considered an adverse childhood experience. The first thing to know about ACEs across the board, and anyone who's had any training on ACEs, you should know, ACEs are incredibly common. These are not just something that happen to some people in some places. In fact, 67% of that original ACE study that was done in the 90s, that was done with a really huge group of participants, 67% of them, 2/3 of them, had experienced at least one of those types of things. So these are not just something that affects some people, they're quite common. And so we have to understand how this also connects to substances and substance use. So ACEs, that stress that we talked about in our brain, basically toxic stress can disrupt organ, tissue, and brain development. So it not only impacts our brain development, but it also impacts how our organs activate and work, how we handle, how our immune system interacts with the outside world. So it can really impact a lot of different parts of our bodies. And so what we see is that ACE scores, and typically around 4 or more ACEs, 4 or more of those experiences I spoke about, are what we consider to kind of be a tipping point to see a real pileup of challenges for people. And so these numbers here, this list here, is for people who have 4 or more ACEs. So they're much more likely to be using substances of all different kinds, whether that's using tobacco substances, alcohol, or other drugs. In fact, people with an ACE score of 6 or more are 46 times more likely to inject drugs than people who have no history of any of those experiences. So it's actually the largest connection between health outcomes and ACEs is tied with using substances to regulate themselves. And we're going to talk more about why that might be. Why would you need substances to help you regulate if you've had a higher level of trauma or adversity early in life? So this is a study that was done in the early 2000s, so still several years ago. But with this study, what they found was that for every increase in someone's ACE score, they were 2 to 4 times more likely to begin using drugs at an early age. And there's a strong relationship between whether you have a high ACE score and whether you start to use drugs at an early age, you actually continue to use drugs and therefore develop what we would consider to have a problem with drug use and eventually developing a substance use disorder or having a drug addiction. And so there's a relationship there that shows that the more ACEs you have, the greater risk you are for one of those. The last piece of this to understand with ACEs is that ACEs are passed down intergenerationally. So let's pause here for a moment, because this is one that's really challenging for us to think about, especially for those of us who have a high ACE score ourselves, is to think about, well, this is the negative piece of I'm passing this down. Well, there's a lot of things we pass down to future generations. If we have a family history of cancer, we pass down that risk factors to our children through our DNA. So there's a predisposition to some of that stuff being passed through our genes, through our DNA. But remember, our experiences are kind of what lead the stage for our children. So experiences are most important, and we'll talk about how do we, what experiences can we do to help kind of redirect people. So if we have someone who has experienced high levels of trauma themselves, what we see in people who have high ACEs is that oftentimes they are at greater risk for depression and anxiety. There is not opportunities for them to have coping skills to manage their emotions. And therefore, what we see is that they have kind of basically they don't feel good inside. And we know that when we've had stressful days, when we've had bad days, that sometimes using things like substances, they help us actually lower our cortisol levels, because substances like alcohol, tobacco, any form of a drug, whether it's legal or illegal, actually offer our bodies opportunities to increase two hormones, and actually many different things, but two in particular in terms of our dopamine and our serotonin. Now, dopamine and serotonin are two hormones that live in opposition of cortisol. So if your cortisol levels are high, if your stress hormones are high, your body cannot also have high levels of dopamine and serotonin, those hormones that make us feel good, that make us feel relaxed or make us feel loved or cared about. And oxytocin is in there as well. So those hormones are low when our cortisol levels are high. And in order to kind of lower our cortisol levels, there's many strategies to lower our stress points. We all can probably think back to a stressful day. What do we do to help us feel good? Some of us might go for a walk, call a friend. Some of us may say, I'm going to open a bottle of wine and have a glass of wine, or I'm going to smoke a cigarette. Or maybe we do a combination of those things. That's the reality of our world. Now, if our stress levels are really, really high all the time because we've been predisposed to that in childhood, what we see often is that it takes a lot more to get our dopamine and our serotonin levels higher, which means we have a much greater relationship with that substance than someone whose stress levels kind of just ebb and flow as natural stress levels do throughout the world. There are also other risk factors that might lead someone to using substances. So it's not just the trauma and adversity that I've spoken about. There are structural challenges in terms of, do we have adverse community environments? What are our social environments look like for people? Are their medical needs met? Their mental health resources met? Is there isolation or a lack of social support in their community? So all of those things we consider to be risk factors. It's not just ACEs, but today's conversation is around that connection right there that I spoke about. In Maine, we ask high school students about their experiences in childhood, both in terms of risk factors that I just mentioned, and in terms of behaviors that they might have, and then also their protective factors. And so we know in Maine that 1 in 5 of our high school students have 4 or more ACEs. So ACEs are very common in Maine as well. And when we look at people's ACE scores and whether they use substances or whether they are challenged with mental health problems like feeling depressed or suicidal, we see a greater relationship between people's ACE score and those risk factors. So you can see here the orange is indicating all of the spaces where if you have an ACE score of 4 or more, and these are for young kids. This is from 2019, but basically, in essence, this is what we're seeing of young people today expressing that they're more likely to drink alcohol. They're more likely to use marijuana. And so again, we think about that early initiation of using substances is starting based off of people's ACE scores. Now, the Maine Resilience Building Network provides lots of training around resilience and how do we counter all of this. So it's important to recognize that while ACE scores give us information about risk factors, they don't tell us that someone is definitely going to have one of those problems. So vice versa too, if you work with families who do have a history of substance use disorders, or you know that someone within their family is, it is not it doesn't mean that they definitely had ACEs in their life, if that makes sense. Those two things, it's not about a diagnosis. But when we understand ACEs, we have a better understanding of what is happening in people's lives. Potentially, we have a better understanding of how we might be able to support people, how we reduce stigma in our community. It gives us a more empathetic lens of why someone might be using substances. or maybe why it's challenging for them to stop using substances as well. So understanding ACEs helps us reframe our response. And again, if anyone in the room has had ACEs training, they know kind of the key takeaway with understanding ACEs is about helping us ask questions about what's happened in someone's life. What are things we can be doing to help them, rather than our mind frame of saying, what is wrong with this person? What is wrong with this mom that I've given them all the resources and they're not following through with it? Or, they've been through treatment and it doesn't seem to be working. Why are they acting that way? Why can't they just get it right? And I don't assume that any one of you actually asked that question, but those are thoughts that sometimes creep into mind when we become frustrated, when we see someone doing something that's different than the way we might do it. And understanding ACEs helps us say that when we understand that some of that stuff might be related to brain development, it might be related to the way that our internal body is working and feeling, and it's about a hormone imbalance, and it's not necessarily about choices that people are making. It really helps us have a better understanding of why someone might be doing something that they're doing, or at least be more empathetic to it. This is from a book called Unbroken Brain, really about understanding kind of the space of which resilience and ACEs plays in addiction. And I think it's a good one because what it's saying is that, just because you have a high ACE score, it does not mean that everyone who has high ACEs develops a substance use disorder. In fact, they say, moreover, most people who experience childhood trauma do not develop substance use disorders because humans have a remarkable tendency towards resilience. Substance use is just one of the many ways in which we cope. And since coping behavior is essential for psychological survival, coping methods become learned early in life and become deeply ingrained in the brain. And so that's what we want to think about. How are we offering opportunities for learning coping strategies that are healthy versus learning coping strategies that help us balance out those hormones in a way that might be harder for us to break that habit later down the road? So anyone who's been through one of our resilience trainings or any of our trainings, you know how we talk about resilience. We talk about it as the capacity for us to adapt under difficult circumstances. And that's important because it's about adaptation. It's not just about handling challenging situations, but how do we adapt and learn those coping strategies I just spoke about in a way that helps us build in a strategy so when more challenges come our way, we know how to handle that and we don't resort back to some of those other coping strategies that may be unhealthy for us. So common resilience factors, common ways in which we build resilience, and is around having really strong connections. So when I said, when you think back to a stressful day, what do you do? And I said, some people might call a friend. That's our strong social connection. That's increasing our oxytocin levels in a way that's healthy and a good strategy for us. Also, having good emotion awareness, being able to express our emotions, and having an internal sense of control over those emotions are all really strong ways in which we build resilience and we have resilience. Having problem-solving skills so we don't become frustrated very easily and have those stress levels increase for us. Having the ability to be optimistic when we are faced with challenges, be able to ask for help when we need help. All of these things are ways in which we build resilience in a good way. And this is a quote from Body Keeps the Score. And I think it's a really important one when we think about, again, that connection to using substances, that self-regulation depends on having that friendly relationship with your body. And when we don't have that friendly relationship, when we're not having those good balancing between stresses and good hormones, which happen as day to day, we rely on external regulation. It's just what we need to survive. Everyone needs it to feel better and to survive. So sometimes that's in the form of medication, like drugs like alcohol, or constant reassurance for someone else, or compulsive compliance with the wishes of others. So for some people, this might be that regulation comes through substances that can be a substance use disorder, but for some people, it might be through being codependent with someone else, needing somebody else to tell us it's going to be okay, or that we have to meet their needs, and that might be damaging to us. So self-regulation needs some sort of, we need support for self-regulation. And so sometimes we're able to regulate ourselves on our own with strategies that we just spoke about, but other times we rely on other measures like substances to help us regulate our emotions that help us kind of stay in line. So let's talk about what helps us feel better when we don't have that good self-regulation or that friendly relationship with our body, as that quote just spoke to. So again, we talked about dopamine and serotonin, and this is also mentioning noradrenaline, which is another hormone that helps us feel better. It lessens feelings of anxiety and depression, lessens our feelings of feeling hopeless or other negative thoughts. So we naturally produce these hormones through many different ways. So again, many substances offer opportunities for us to release dopamine and serotonin and noradrenaline and oxytocin, all of those hormones that make us feel good. But we also naturally produce those hormones through these different things. So things like feeling safe, feeling like you're connected with other people, like that you want to laugh. Those are ways we naturally produce those. We also produce them through things like our diet. The reason we like to have chocolate at the end of the day, I don't know about you all, but I'm definitely have that sweet tooth after a meal, is because it actually helps us kind of relax a little bit. It makes us go, that's our dopamine right there, and our serotonin going, that's that feeling. That's that good hormone. So we get it through things like the food we eat. We get it when we exercise, when we move our body. And then we also get it when we practice regulation skills, like taking calming breathing activities or practicing mindfulness, or naming our emotions, reducing our feelings of shame or blame within ourselves, reducing internal stigma that we might carry about ourselves. The other thing for us to think about too is that people who are using substances right now, and we're trying to offer them some resilience strategies, we want to think about the fact that not every resilience strategy works for everybody. So same thing for everyone in the room right now. You may have some strategies that work really well for you, and some of the other ones you're like, yeah, I never really felt like that worked for me. So thinking about this, if we are working with someone who uses substances and we're trying to kind of offer some other strategies for them to help them build their resilience, or you're working with someone's like caseworker who might be helping in this space, is thinking about what kind of types of resilience strategies may line up with their drug of choice. So depressants, for instance, those are things like alcohol, marijuana is considered a depressant. Those are drugs that kind of slow us down, slows the body down. It makes us feel more relaxed. It calms our nervous system. So activities that are resilience building that do the same thing, that help slow us down, feel relaxed, calm down our nervous system, are in the form of breathing activities, meditation, yoga, looking at art or producing art. Those omega-3s and diet-related things are all things that can also have those same effects. Now, if someone is more inclined to feel the need to have an upper, so that they're not looking for feelings of relaxation, they're looking for feelings of focus, or they have extra energy and they're trying to release that energy, activities that kind of do those things that are resilience building involve intense exercise. So rather than like going for a walk, they may be interested in training for a race, or trying rock climbing, or riding bikes in a race, something like that. Any of those kind of intense exercises that release endorphins and kind of give that euphoric feeling might be good for someone who might be using opioids, and trying to come away from that. Other things is connecting with other people. So connection one-on-one could be really good for someone who is more in the state of trying to relax and looking for that connection. But social environments where you're making connections with lots of people. So looking at group settings where there's a bigger group, that connection can have that same kind of upper feeling that someone might be getting from a substance. So again, these are suggestions for if that is relevant in the work you're doing, but recognizing that resilience strategies aren't one size fits all. Resilience strategies might be more aligned with the drug that someone has preferential treatment towards, and their strategy might fit better in that space. So that connection with other people is something that we know is really beneficial for everybody. And so, like I said, connection with one person can be calming and soothing for some people, and it helps us release some of that negative, stressful feelings. But for other people, that connection may look like connecting with lots of people, having a big, strong social network. And we know that when we see young people making connections, so if you're working with families with young children and thinking about how is their school and family environment creating opportunities for connection, because connection, when we see people who have that strong social network, they're less likely to have engage in risky substance use at an early age. When they have strong connections, they're less likely to have mental health challenges or experience violence in adulthood. And this is a quote we use a lot, but it's just so powerful for us to understand that when we have a strong social network with many, many high quality relational interactions, over time that predicts good mental health and positive outcomes better than traumatic experience predict poor prospects. So when you think back to one of those earlier slides where I said that toxic stress can disrupt our organs, tissue, and brain development, and that there's a higher risk of any one of those conditions I showed you. However, having those strong networks, this is actually a better predictor of good mental health. We know that positive childhood experiences, having positive connections, even in adulthood, helps us protect our mental health better than the trauma and any of our past experiences predict those poor outcomes that I spoke about. So I think it's important for us to understand that if we're interacting with people who are using substances, the best kind of way for us to help build resilient self-healing opportunities for people is in the form of a harm reduction model. I'm considering that basically a harm reduction is a practice, as a public health strategy where you're interacting with someone who is using drugs, and your idea for them is not necessarily that they stop using drugs, it's that they have a good understanding of how that harm might be associated. So harm reduction is a resilience strategy, and there are many different organizations in the state of Maine who are focused on harm reduction and really focused on allowing opportunities to have non-judgmental and safe spaces for people in a way that interacts with their trauma. So the reason why I think harm reduction models are really important is because harm reduction comes in with that lens, that non-judgmental strategy that understands that there might be something else that happened to somebody. So harm reduction in practice is about being non-judgmental, non-stigmatizing way of engaging people who use drugs. It also acknowledges that there are harms associated with the drug, so it's not encouraging drug use, but it's simply recognizing that there might be another reason why someone's using drugs, and rather than simply saying, stop using drugs, it's saying, let me give you options and strategies that might be helpful for you to allow you some control in your life to make the decision of what they would like to do and reduce their harm, whatever that looks like. So community-based prevention strategies, when we think about ACEs and substance use disorder, fall in line with harm reduction programs like overdose response programs, which involves training people on how to use naloxone, making sure people have access to information, helping families who might be interacting with, like maybe there is someone inside their family who has a substance use disorder, and recognizing that there's harm in the space that the child's interacting and seeing those things. So really, how do we reduce the chances of an overdose happening? Increasing access to naloxone is definitely an important strategy. In Maine, we have a Good Samaritan law, which protects people who are being, if there's an overdose emergency situation, protects the people who call to protect that person and make sure they get medical treatment. And in Maine, that was just expanded in this most recent year. There were some flaws in kind of our past law that was introduced in 2019. So that's a big win for the state of Maine in terms of reducing harm and reducing overdoses, which are harmful for families altogether. I also just want to kind of highlight that programs who offer harm reduction work and are trying to reduce harm for people do a lot more than simply offer safe needles. For instance, like a syringe service program is a harm reduction program. And you can see here that there's a lot of different services, and you may interact with other programs that do some of these services, which is fantastic, making sure that they are trauma informed, meaning they recognize the role that trauma plays in the lives of people, and are meeting people where they are in their process of receiving care. So someone may not be in a space where they're ready to stop using drugs, and you may have a lot of concern over that, but making sure they're connected with a program that can at least ensure that they're getting active reproductive health services, or making sure that they have access to overdose education and that they have naloxone, so that if there were to be an overdose, that someone can help them. Making sure that they have access to treatment planning when they're ready for that. All of those different ways in which we can offer reduce people's harm is a great way for us to meet them where they are without ignoring the fact that they've experienced some sort of trauma, and it may be hard for them to stop using drugs right away. So I'm going to stop right there and check in with the chat. And Sam, I'm not sure if you're able to help me to see if there's been questions come in while I've been presenting, because I just cruised through that for you all.
Right. It looks like, thank you, by the way, that was great. We do not have any questions in the chat at this moment, but does anybody have any questions or comments? You can feel free to unmute yourselves or write something in the chat and I can read it out to everybody.
And I'll stop sharing too. If anyone wants to unmute, feel free. I went through a lot of different information and I don't know people's initial knowledge level. So even if you had questions way back at the beginning about that brain development and ACEs, I'm happy to answer that, or more about that connection between the ACEs and substance use.
Okay, we do have a question. First, thanks. It says, thanks, Ruby. Is there an optimal age to start introducing coping strategy to kids for lifelong use?
That's a great question. So one of the things we talk about resilience is that there's no kind of right point of like, oh, if you didn't get resilient strategies now, sorry, you're out of luck, or vice versa, like, okay, at this age, we have to do it because after that point, we don't have anything. So if you think back to that brain development piece that I talked about, there's obviously really great information to tell us those first several years of a child's life are incredibly important in their brain development. However, our brains develop well into adulthood. So, even in our early 20s, we are still forming our brain. And so therefore, our ability to build in resilience strategies are still very much effective at that point. So all of that to say that there is, the earlier we offer opportunities for resilience, the better it is. And the key for kind of hopefully delaying the onset of using substances or preventing it altogether is really around, do children have strategies for reducing stress in a healthy way? That stress reduction opportunities are going to be the things that are really key for helping them kind of fight any toxic stress that they may have in their own environment that we may not have control over. So making sure that they have strategies that reduce their stress levels. And so hopefully they kind of are able to, on their own, kind of counter some of that stress that may be happening, and they're less likely to start using substances. So I have one more thing to say about that, and then I'll wrap up that question. But think about this. Young people who have, think about our middle school days, our even elementary school days for some of us. When was it that we first either ourselves were introduced to some sort of a substance, whether that was alcohol or cigarettes or marijuana or any other substances? What happens is that someone who's experienced trauma and they start that at that age, there's going to be a very different internal reaction to that than someone who's not experienced trauma. So for the families that we're working with, or for children who we know who do have history of ACEs, they have that in their childhood. If they're introduced to that at any one of those ages, they're going to find that that feels really good inside their body, in a way that someone who hasn't experienced trauma, who doesn't have that constant feeling of stress inside their body, might use marijuana and be like, oh, this was kind of cool, but there's not that kind of bodily connection with it. And so that's where what we want to do is offer resilience strategies to hopefully delay substance onset, at least even a couple of years, because it gives the brain more time to develop. It gives their body more time to kind of learn how to regulate their own stress levels without relying on a substance to regulate our stress levels. So I hope that was helpful and answered that question.
Great, thank you. Great question, Tasha. Any other questions?
Ruby, this is Ginger. It's not really a question, but just a statement more that everything you just said just makes so much sense. So thank you for sharing it with us.
Great. I'm glad that was helpful. I think it's a good way for us to take time to kind of consider why some of our families may really have this be part of their history or by their current challenges right now. And really recognize that it's not always a matter of, when I talk about this, our current substance treatment model in many spaces is often saying, stop using the substance. We're trying to treat when we say addiction treatment services, we're trying to treat the drug rather than trying to treat the person, which would be a trauma-informed model, where we actually are saying there's a reason why someone's using a substance to begin with. If we treat the person, if we treat the reason why they're using substances, we actually probably have a better chance of helping them reduce that drug use and potentially leave it behind altogether if we offer those resilience strategies, if we recognize the role in which trauma plays and how we need to kind of supplement what it is that the drug was making their body feel like. So I think that those kinds of things can be really helpful, whether that's our role, and it may not be some of your roles at all, but at least having that understanding can be a really helpful way of when you're interacting with families. And when you offer kind of other strategies for them, you may be offering resilience building strategies that might be beneficial for the whole family, and that your intention maybe was just to work with one, but you'll find that those resilience strategies, any emotion regulation strategies, are going to be beneficial for everybody.
We just had a comment from Jackie. That point makes really makes so much sense. Thank you.
Great, good. I'm glad that was helpful. Any other questions people have? Anything I didn't cover you thought might have been covered in this? That might be something that you might have a question about. And again, feel free to unmute yourself. I'm happy to talk.
Right.
Anything else come in, Sam?
No, nothing yet.
Okay.
Oh, wait. Oh, no, I don't have any questions, but thank you. That was a good comment. Thanks, Elena. But if you do think of any questions, you can feel free. If I think you all have my email, you can send it to me and I can get it over to Ruby. Or you guys might have Ruby's email from the calendar invite, so you can reach out to her. But thank you so much, Ruby. That was wonderful, and we really appreciate your time being here with us today. That was very, very deep and thorough. So thank you so much.
Great. Thank you guys all so much. I hope it's helpful. My email is Ruby, RUBY, at mainresilience.org. So if you do have further questions, or you're like, I'm really intrigued and I need to know more, totally reach out to me. I'm happy to offer other, resources or strategies or anything else that would be helpful in your work. So, thank you all for attending today.
Awesome. Thanks, everybody. Have a great day.
Thank you.